Hello and welcome to DocAT. In today's video, we're going through the critical topic of mixed shock. What it is, why it happens, and how to respond effectively. Let's break it down together. Mixed shock refers to the combination of two or more shock types, such as septic shock leading to cardiogenic and hypovolemic components. Here are some examples of mixed shock. 1. Septic shock with cardiogenic features. Sepsis causes systemic vasodilation and capillary leak, which is distributive shock. Myocardial dysfunction, induced by inflammatory mediators like cytokines, reduces cardiac output, adding a cardiogenic component. 2. Trauma-induced mixed shock. Hypovolemia results from blood loss. Obstructive features may arise from tension pneumothorax or pericardial tamponade. And there's potential distributive shock due to the systemic inflammatory response from tissue injury. 3. Cardiogenic and hypovolemic shock. For example, a patient with acute myocardial infarction who also experiences gastrointestinal bleeding or trauma. 4. Post-cardiac arrest syndrome. Hypoperfusion arises from cardiogenic causes, like myocardial stunning. Meanwhile, distributive shock occurs due to ischemia reperfusion injury and systemic inflammation. Clinical features. Mixed shock manifests with a combination of signs. Often, features of the dominant shock type are more noticeable early on. Some general signs include hypotension, tachycardia, altered mental status, oliguria, metabolic acidosis, and elevated lactate levels. But specific symptoms depend on the shock components. Hypovolemic, cool, clammy skin, weak and thready pulse, narrow pulse pressure. Cardiogenic, distended neck veins, pulmonary edema with crackles, and a low ejection fraction on echocardiography. Distributive, warm, flushed skin in early stages, fever from sepsis, or signs like urticaria and angioedema and anaphylaxis. Obstructive, distended jugular veins, absent breath sounds in tension pneumothorax, or pulsus paradoxus in cardiac tamponade. Diagnostic approach to mixed shock. Accurate diagnosis of mixed shock is vital and requires clinical evaluation, laboratory testing, and imaging. 1. Hemodynamic monitoring is essential. Central venous pressure estimates preload. Pulmonary artery catheterization measures cardiac output, systemic vascular resistance, and pulmonary capillary wedge pressure. Echocardiography provides a non-invasive assessment of cardiac function and fluid status and presence of obstructions. 2. Laboratory tests to consider. Serum lactate for tissue hypoperfusion. Arterial blood gas to check acidosis, hypoxemia, or hypercapnia. Inflammatory markers like CRP, procalcitonin, and IgE. Troponins to detect myocardial damage. 3. Imaging studies. Chest X-ray for pneumothorax or pulmonary edema. CT angiography for pulmonary embolism. The FAST exam for intraperitoneal bleeding. Management of mixed shock. Managing mixed shock involves restoring tissue perfusion and treating the underlying causes. 1. General supportive measures include oxygen therapy or mechanical ventilation, IV access for fluids and medications, continuous hemodynamic monitoring in the ICU. 2. Specific interventions for each component. Hypovolemic shock, rapid fluid resuscitation or blood transfusions. Cardiogenic shock, inotropes like dobutamine to improve cardiac output. Diuretics for pulmonary congestion or mechanical support like ECMO. Distributive shock, vasopressors such as norepinephrine to counteract vasodilation and broad-spectrum antibiotics treat infection. 4. Anaphylaxis, antihistamines, corticosteroids, and epinephrine. Obstructive shock, relieve obstructions with needle decompression, chest tubes, or thrombolysis. 3. Adjunctive therapies include corticosteroids in septic shock refractory to fluids and vasopressors, bicarbonate for severe metabolic acidosis, and anticoagulation for pulmonary embolism. General principles of shock management. Let's not forget the ABCD approach for shock management. Airway, breathing, circulation, disability, and exposure. Airway. Ensure airway patency and provide oxygen support. Breathing. Correct hypoxia with supplemental oxygen or mechanical ventilation. Circulation. AOIV fluids for volume support, crystalloids or blood products. B vasopressors, e.g. norepinephrine. if fluid resuscitation fails to stabilize blood pressure. C's correct electrolyte imbalances and acidosis. Disability, assess neurological status. Exposure, identify injuries or other signs of the underlying cause. Definitive treatment, identify and treat the underlying cause, e.g. infection, bleeding, obstruction. Monitoring, continuous blood pressure, oxygen saturation, and urine output. Hemodynamic support, e.g. arterial line, central venous pressure. Urine output, key indicator of perfusion, greater than 0.5 milliliters per kilogram per hour. Prognosis, depends on type, cause, and timeliness of intervention. Early aggressive management improves outcomes, especially in septic and cardiogenic shock. This detailed overview serves as a guide for the recognition, diagnosis, and management of shock in clinical practice. Early intervention and comprehensive care are critical for survival. And that's a wrap on mixed shock. If you found this video helpful, please like, share, and subscribe for more medical insights. Drop any questions or comments below. We'd love to hear from you. See you in the next video.